Welcome to Unit 6, Chemoprevention to Accelerate Malaria Elimination. This unit covers the use of chemoprevention strategies to accelerate malaria elimination. By the end of this session, you should be able to explain how chemoprevention reduces transmission by both curing existing infections and preventing new infections for a period of time. Describe why and under what circumstances chemoprevention strategies are recommended for elimination of malaria. And specify the critical factors that optimize the impact of chemoprevention for transmission reduction in elimination settings. You may remember the transmission continuum that featured prominently in Units 0 and 1. Component C is the accelerator step. There are several different chemoprevention strategies that could be included in this step, and there may be other new tools or strategies in the future. Component C starts when the country has already successfully scaled up the basic package of interventions, has sufficiently strengthened the surveillance system, and is ready to begin Component D, that is, investigating and clearing individual cases and foci as soon as transmission is low enough for it to be feasible. The point of Component C is to rapidly reduce transmission such that the country or area can begin Component D, or to supplement the investigation and clearing of individual cases with additional transmission reduction measures. In this session, we will review several chemoprevention strategies recommended by WHO in certain situations to accelerate malaria elimination. Chemoprevention is the use of anti-malarial medicines for the treatment and prevention of malaria. Chemoprevention involves the provision of a full therapeutic course of anti-malarial medicine to everyone eligible, often at repeated intervals. Chemoprevention is given whether or not someone has symptoms of malaria and without testing individuals for infection. It will cure all existing infections and prevent new ones over the prophylactic period of the medicine, usually several weeks. Chemoprevention is a broad category of drug-based interventions that include mass drug administration, MDA, seasonal malaria chemoprevention, SMC, intermittent preventative treatment of malaria in pregnancy, IPTP, and perennial malaria chemoprevention, PMC, or what used to be called intermittent preventative treatment in infants, IPTI. Chemoprophylaxis is different from chemoprevention because it is meant to prevent new infections but does not cure any existing infections. Currently, chemoprophylaxis is recommended for non-immune travelers to areas with ongoing malaria transmission. Since 2022, WHO has greatly expanded its recommendation around chemoprevention and recognized that chemoprevention can be used to reduce the burden of disease, as with IPTP and SMC. However, in certain settings, chemoprevention may also be used to reduce transmission of malaria to accelerate progress towards malaria elimination. WHO recommends 3 types of chemoprevention to reduce malaria transmission in areas approaching elimination. The first is MDA, to reduce transmission of Plasmodium falciparum in areas of very low to low transmission or to reduce transmission of Plasmodium vivax. MDA is provided to the entire population of a delimited geographical area at the same time, hence the use of the word mass. The second recommendation is for targeted drug administration, or TDA, which is a form of chemoprevention provided to people at increased risk of infection compared to the general population. For example, TDA applies to populations who may be exposed to malaria transmission because of their occupations, such as mining, or because they generate their income in places at high risk of transmission, such as people who farm in forest or who obtain resources from forest. In a TDA program, only certain people with specific risk factors out of the population of an area would receive chemoprevention, hence the use of the word targeted. Finally, WHO recommends reactive drug administration, or RDA, which is the provision of chemoprevention to those living with or near a confirmed case of malaria in very low transmission settings. We have already reviewed reactive strategies in the Unit 5 on surveillance and response. In addition to RDA, WHO recommends reactive IRS and reactive case detection and treatment where cases are very few. We will take the next few slides to go through each of these strategies. When transmission of malaria is generalized across a community, meaning that the risk of malaria is not concentrated in a particular risky group and everyone is more or less the same risk of infection, MDA might be an appropriate chemoprevention intervention to accelerate the reduction of transmission. MDA works by reducing the malaria parasite reservoir in humans through the treatment of existing infections and prevention of new infections for a short period of time. However, not all infections are eliminated by this strategy. First, not everyone can take the medicine for safety reasons. Second, there are always some people who decline to participate. Third, the medicine in MDA do not currently affect malaria infections in the mosquito vectors in the area. And finally, both mosquitoes and humans can quickly import infections into the community if it is too close or too connected to other malaria endemic areas. To have an important or lasting impact, it may be necessary to conduct multiple rounds of MDA over several years. If MDA were to be conducted in the community pictured on this slide, then everyone for whom the anti-malaria medicine is safe would be provided with a full treatment course at approximately the same time. MDA can be done in a small area like a village or in a large area like a district. The important factor is that the population included in the MDA program does not move in and out too frequently, and that the community provided with MDA is not adjacent to or near another malaria endemic community. WHO recommends considering the use of MDA for the elimination of Plasmodium falciparum in areas of very low to low transmission as one of several components of a robust malaria elimination program. The elimination program should include, at a minimum, good coverage of case-based surveillance, effective anti-malarial treatment, and other prevention tools and strategies, such as vector control. These additional elements are needed because MDA might quickly reduce transmission of Plasmodium falciparum, but the effect wanes with 1 or to 3 months. Therefore, a robust malaria elimination program is needed to reduce the risk of resurgence after the MDA program is ended. MDA is recommended for the reduction of Plasmodium falciparum transmission in all areas with prevalence below approximately 10%. This threshold is not an absolute cutoff, but a general guidelines on where MDA might have the greatest effect on Plasmodium falciparum transmission. The decision of whether or not to implement MDA to accelerate elimination efforts should be made after careful considering several important factors to determine whether conditions in the area are likely to lead to an optimal outcome. First, MDA is not a substitute for functioning health system and other prevention tools and strategies. Core malaria interventions must be in place and functioning adequately, or MDA is not likely to be successful. Without good access to diagnosis and treatment and other prevention strategies, any gains from MDA are likely to be quickly reversed. Second, effective case-based surveillance should be in place before MDA is implemented, because the goal of MDA is to reduce transmission sufficiently such that a well-functioning surveillance system is able to identify new cases, investigate them to identify the likely location of infection, and then intervene to reduce more infections. If the surveillance system is not functioning properly, any gains from MDA are unlikely to be sustained. Third, MDA is unlikely to be effective or gains unlikely to be maintained in areas close to other malaria endemic populations or where there is significant movement of people. In areas where there are a lot of people moving in and out, MDA is not likely to have significant impact for two reasons. Because many people will have missed out on receiving the anti-malarial medicine during the campaign, and because new infections will quickly reintroduced into the population. Therefore, MDA is likely to have the greatest impact in areas that are isolated, such as islands, and where or when there is little movement in and out. Finally, malaria programs should carefully consider whether there are sufficient resources to implement MDA without affecting other components of a robust malaria elimination program. In 2022, WHO recommended MDA for the reduction of Plasmodium vivax transmission for the first time. This recommendation was based on very low certainty evidence from studies that demonstrated a short-term reduction in transmission of Plasmodium vivax after MDA was implemented. As with the recommendations on MDA for Plasmodium falciparum, WHO recommends considering the use of MDA to reduce transmission of Plasmodium vivax as one of several components of a robust malaria elimination program. The best outcomes will occur in isolated geographical areas where there is limited movement of people, and malaria programs should carefully consider whether there are sufficient resources to implement MDA without affecting other components of a robust malaria elimination program. Most of the studies reviewed for this recommendation did not use primaquine for radical cure of P. vivax. it is possible that the effect of MDA on P. vivax transmission might have lasted longer if primaquine had been administered to prevent relapses. However, use of primaquine for radical cure in an MDA setting is quite challenging. We will discuss this in more detail later in the unit. WHO also recommends considering MDA during emergencies or epidemics to reduce the burden of Plasmodium falciparum. The objective here is not to eliminate transmission, but to achieve immediate reductions in morbidity and mortality due to malaria caused by Plasmodium falciparum. When emergencies occur in malaria endemic settings and the health system is not performing well, malaria often becomes the most important cause of outpatient visits, inpatient admissions, and deaths. MDA can be considered in emergency settings to rapidly reduce illness and death or to reduce the burden of malaria on the health system. Although not the topic of this training course, MDA is also recommended for reduction of the burden of Plasmodium falciparum malaria in moderate to high transmission settings. Let's consider the second chemoprevention strategy, TDA. TDA can be used for both Plasmodium falciparum and Plasmodium vivax. We learned in Unit 2 that as malaria transmission declines to very low levels, it often becomes concentrated in individuals who are exposed to outdoor biting, such as people who work in the forest, or those whose occupations or activities leave them exposed to mosquito bites at night. In this case, malaria is not generalized across the population. It is concentrated in certain groups with most exposure to malaria vectors. If the epidemiology of malaria in an area clearly shows that most cases are occurring in people with easily identifiable risk factors, it is more equitable and probably more acceptable and efficient to provide chemoprevention to that group alone through TDA. In this community, data from the surveillance system indicated that people who work in the mines and those who participate in evening sports are at the greatest risk of malaria. As a result, the malaria program identified miners and football players and asked them to participate in a TDA program. Those who agree to participate will receive a full therapeutic course of an anti-malarial medicine over several rounds during the transmission season. The program will monitor malaria transmission in the community to determine whether TDA has an impact on malaria transmission. It is important that targeting certain individuals for chemoprevention does not lead to feelings of shame or social stigma. Engagement with both general community and the population affected by malaria is critical to ensure understanding and an acceptable approach to TDA. If a program is considering implementing TDA for Plasmodium vivax, careful consideration is needed to plan the program so that it is possible to safely and feasibly administer treatment to prevent relapses. Finally, we have the last chemoprevention strategy recommended in areas approaching elimination, RDA. RDA is the provision of anti-malarial medicine to everyone living with or near a confirmed case of malaria at approximately at the same time. In this slide, a member of the family in the household, glowing blue, has been diagnosed with malaria. The case investigation has been completed and the case is classified as indigenous with the likely location of infection at the homestead. As we learned in Unit 2, if there is any additional cases clustered around the index case, they are most likely to be found in the household of the index case. Residents of the same household as the index case should be included in an RDA program. Additionally, chemoprevention can also be provided to those who share the same risk of infection as the index case, such as co-travelers or co-workers, depending on the likely location of infection. Malaria programs should decide whether they need to extend chemoprevention to neighbors of the index household. The malaria program should specify in the protocol the radius of the intervention, which should be determined based on the spatial and temporal patterns of malaria they have found in the surveillance data or understanding of the malaria epidemiology in the area. Whatever radius is decided for RDA, the feasibility and impact of treating people within the radius should be monitored and evaluated to determine whether the intervention is appropriate. To implement RDA properly, programs should enumerate the population at risk and follow up to ensure that everyone eligible received the medicine. If a program is considering implementing RDA for Plasmodium vivax, as we have said, careful consideration is needed to safely and feasibly administer treatment to prevent relapses. When countries get very close to elimination, it will be important to implement reactive case detection in addition to RDA To improve the sensitivity of the surveillance systems, countries may also choose to implement reactive IRS as well. All of the three chemoprevention strategies discussed, MDA, TDA, and RDA, can be used to reduce the transmission of both Plasmodium falciparum and Plasmodium vivax. As you remember from Unit 2, Plasmodium vivax has a pinozoid stage in the liver that may relapse and cause a new blood stage infection months to years after the initial infection. Without specific treatment with a drug from the 8-aminoquinoline class, which includes primaquine, the liver stage of the parasites cannot be treated and the relapses will occur. Chemoprevention programs for P. vivax that do not include this medicine may be less effective. Although we have no evidence to say for sure what impact radical cure may have in chemoprevention programs, the dosage of primaquine required to cure liver stage parasites can cause hemolytic anemia in people with G6PD deficiency. WHO recommends G6PD deficiency testing before primaquine is given. Adding this testing to chemoprevention strategies is likely to complicate the program. To safely provide a full therapeutic course of primaquine in a chemoprevention program, in addition to testing the G6PD deficiency prior to treatment, an effective pharmacovigilance system and emergency access to blood transfusion services are needed. The take-home message here is that programs that are considering adding radical cure to chemoprevention strategies should consider this carefully and determine how they will safely administer the treatment. Programs should also consider whether sufficient coverage and adherence to the full course of radical cure can be achieved in their setting. WHO does not recommend use of an 8-aminoquinoline as part of the mass relapse campaign or what has been called spring treatment in temperate areas with P. vivax, such as Eastern Europe. If a malaria program wants to implement a mass chemoprevention strategy for P. vivax and has carefully considered how to safely include radical cure with an 8-aminoquinoline, it is better to provide the radical cure along with an artemisinin-based combination therapy. Please break into pairs and consider these 4 questions. Take turns providing your answers to these questions. Be prepared to report back verbally to the plenary. With respect to malaria elimination, what is the goal of chemoprevention? In your area or country, are there any communities where MDA will be an acceptable and feasible intervention to accelerate malaria transmission? Why or why not? TDA is similar to MDA, but anti-malarial medicine is only given to individuals at high risk of infection. Are there any groups of individuals at high risk of infection in your area? Would TDA be a reasonable intervention? Why or why not? Does your country or area implement any reactive strategies? If so, would RDA be an acceptable and feasible chemoprevention strategy? Why or why not? The success of chemoprevention in reducing malaria transmission depends on several operational aspects, and we know from the mathematical modeling efforts that there are some operational factors that matter more than others. Population coverage with chemoprevention is a key factor affecting the degree to which transmission will be reduced. Increasing the coverage of MDA programs from 50% to 90% more than doubles the percentage reduction in malaria prevalence that can be achieved. Coverage can be improved through a well-designed campaign that includes an effective communication and community engagement strategy. Coverage will be measured differently depending on the chemoprevention strategy used. In MDA, the entire population is provided with chemoprevention, and the number of people who accept and take the anti-malaria medicine is compared to the total population. In TDA, the denominator is the number of people in the higher risk group. In RDA, the denominator for coverage is everyone within the intervention radius of the index household. Most of the mathematical models examining MDA have found that a key factor determining the impact of the strategy is the proportion of the total population that never participates, even after multiple rounds. This means that all rounds of chemoprevention after the first round should prioritize finding and treating the people who weren't treated in the first round. If the same people are missed in each round, the impact of chemoprevention strategies will be lower. The timing of the rounds of chemoprevention can also have an effect. Most mathematical models have found that implementing MDA during periods of low transmission, for example, in the dry season or just before the peak of transmission, will have a greater impact than conducting the rounds during the high transmission period. Timing is important for MDA and TDA, but not for RDA, because the timing of RDA is determined by the occurrence of a confirmed case. Mathematical models have also found that MDA will have a greater impact if it is implemented over several years. The proposed length of MDA and TDA programs should be considered in advance and communicated to the population to manage expectations. As the RDA strategy is usually continued until elimination and even post-elimination to prevent re-establishment, it is not possible to determine the number of years of the program in advance. Finally, the safety of chemoprevention is of paramount importance both for ethical reasons and for the impact that safety consideration can have on participation. There must be a well-functioning pharmacovigilance system to identify, manage, and report any adverse events that could occur. The community should be educated on the potential minor side effects that the medicine can provoke so that they are prepared for reports of these adverse events during the campaign. Additionally, the community should understand that a well-functioning pharmacovigilance system is in place to identify any more serious adverse events and should they occur so that the organizers can rapidly adjust the campaign to ensure safe intervention. As with all malaria interventions, engagement of the community is essential for chemoprevention strategies to be effective. Ensuring full participation in a chemoprevention program requires building mutual understanding and trust in the institutions implementing the intervention. Acceptance and uptake of the medicine by members of the community who are not feeling ill and have not been shown to be infected with malaria will depend on several factors. First, the general malaria risk perception in the area. In elimination settings, where malaria has ceased to be a major problem for some time, there needs to be a messaging around why chemoprevention is needed and why elimination of malaria is important. Second, community members should understand why they are being asked to take a medicine when they are not feeling ill. Explaining that the drug not only cures anyone who might be infected, but also provides a period of protection from future infections can help to clarify this issue for the people. Third, the community needs to be made aware of the potential side effects of the medicine in advance of the rounds of chemoprevention. Reassuring the public about the minor nature of the side effects and explaining to them what to do to manage side effects will help to raise confidence in the program. A communication plan should be developed and agreed upon by the Ministry of Health and other partners with specific strategies for reaching targeted audiences. The key behaviors needed by the community should be explained clearly. Additionally, community mobilization before chemoprevention programs is critical to ensure that key behaviors are promoted. A community engagement plan should be developed to promote cooperation with local leaders and other influential members of the community. There are three possible distribution strategies for chemoprevention program: door-to-door distribution, centralized distribution at a fixed site, and a combination of door-to-door and centralized fixed site distribution. RDA is almost always going to be delivered door-to-door unless the area is very large. However, for MDA and TDA, the choice of strategy will depend on logistical capacity and analysis of the local context, including security and any outbreak or other special circumstances. The preferred strategy is door-to-door distribution because it generally results in higher population coverage. Door-to-door strategies also facilitate monitoring of campaign coverage. There are challenges with the door-to-door approach, and a pilot program is recommended to work out the likely distribution challenges in advance of the full intervention. The combination approach could consist of a centralized fixed site and then door-to-door distribution for hard-to-reach groups. Alternatively, door-to-door distribution could be followed by centralized distribution to follow up missed participants. TDA strategies could focus on areas at risk, such as setting up TDA points along routes known to be traveled by people working in the forest or participating in illicit or illegal activities. Distribution points could also be established at work sites such as plantations or mining camps. One of the most important decisions that the National Malaria Program will make early in the planning for a chemoprevention program is the choice of anti-malarial medicine. The anti-malarial medicines chosen for use in chemoprevention should be WHO recommended and pre-qualified, be efficacious against local parasites, be different from the medicine used as first-line treatment where possible, have a superior safety and tolerability profile, provide a longer duration of post-treatment prophylaxis with component medicines that are closely matched pharmacology to reduce the risk of new infections encountering only a single drug, have a positive public reputation and acceptability, and be available and low cost. Programs in areas with P4 may consider including a single low dose of primaquine in chemoprevention programs in order to increase the gametocytocidal effect. Although there have been no studies of whether this improves the effectiveness of chemoprevention strategies, a drug regimen that can be administered as a directly observed single dose is preferable to multiple day regimens. A complete therapeutic course of anti-malarial medicine at doses recommended by the manufacturer should be given to all eligible adults and children. Drug dosage should be determined by weight wherever possible, with dosing according to age only in situations where the patient's weight is unknown. Once the medicine for chemoprevention has been selected, improving adherence to the full treatment dose becomes a consideration. As current anti-malarial therapeutic courses are multi-day treatments, treatment compliance is a challenge for chemoprevention programs. Directly observed therapy, DOT, is the preferred strategy for ensuring adherence and reducing the potential for mistakes in taking the medicine. Although DOT is more challenging operationally, it has been used successfully in very large-scale campaigns, including with multi-day drug regimens. As it may not be feasible to give all 3 doses of an ACT by DOT, a health worker may administer the first dose and give the remaining tablets to the person or caregiver for days 2 and 3 of the intervention, with instructions on their administration. Because of the high risk of non adherence to treatment on the 2 days following the administration of the first dose by DOT and consequent misuse of the medicine, adherence must be strongly emphasized both by the distributor and in social mobilization campaigns. An alternative that promotes and enables assessment of adherence to treatment and safety is giving the first and third dose by DOT. These different delivery options, full DOT, DOT on days 1 and 3, and DOT only on day 1, have resource implications that should be considered when planning the intervention. Chemoprevention campaigns present significant challenges to national malaria programs. Programs should carefully consider the workload, risks, and implementation challenges before deciding to use a chemoprevention intervention. This slide illustrates some of the important implementation challenges facing chemoprevention programs. The time of day when the antimalarial medicine is provided should coincide with the time when people are at home or a time when they are likely to access the distribution point. This may require some flexibility in the work schedules of the staff implementing the chemoprevention program to ensure that medicines can be provided at the best times for the population. Mobile, migrant, and remote population can be hard to find and engage in chemoprevention. Recruiting members of these communities to serve as medicine dispensers is one way to address the problem. Community engagement and effective communication is necessary to ensure that everyone understands why the chemoprevention campaign is being conducted and that individuals may harbor parasites without feeling ill. Explaining to people how the medicine will kill parasites if they have them and prevent new infections for a period of time after taking the medicine can help to improve coverage and adherence rates. Certain characteristics put some groups at greater risk of not participating. People of a higher socio-economic status and men have been found to be less likely to participate in chemoprevention programs. Communication messages aimed at these groups should be prepared to ensure a high coverage rate. Significant movement of the population into and out of the area targeted for MDA can reduce the impact. People who are away at the time of MDA program will not be protected from new infections when they return, while some may import parasites back into the area. The size of the area targeted for MDA should be large enough that it minimizes the effect of this movement. Mop-up and fixed post strategies could be used to capture individuals who were not present during the MDA campaign. There are some risks with chemoprevention interventions that need to be carefully considered before beginning any chemoprevention program. First, there is a risk of low population coverage or systematically missing the same people over multiple rounds. Without a well-planned program with a good community engagement strategy, the coverage might not be sufficient to have a significant impact. Modeling efforts suggest that effective population coverage, defined as the proportion of the entire community, not just those eligible, that participates in MDA, should be greater than 80% to achieve impact. We don't have such data for a TDA or RDA, but High coverage rates are likely to be just as important within those strategies. Second, those participating in chemoprevention must take a full course of antimalarial medicine. ACTs must be given over 3 days. Therefore, the logistics required to ensure that the entire eligible population receives all 3 doses is considerable. If the community is fearful of the campaign and hasn't been adequately engaged to understand the reason of the campaign and the safety profile of the antimalarial medicine being used, adherence is likely to be low and impact will be reduced. With the use of an 8-aminoquinoline to prevent P-Vivax relapses, the need for full adherence to the treatment course becomes critical. Adverse drug reactions are a risk. Even when medicines with good safety and tolerability profiles are used, exposure of people to antimalarials may result in the appearance of rare adverse events that may or may not be related to adverse drug reactions. A good pharmacovigilance system is needed to systematically gather information on adverse events. There must also be a system in place to manage adverse events correctly to ensure the safety of participants and to report any events quickly to enable effective communication with the public. Additionally, rapidly gathering information on adverse events enables modification to the campaigns that may be warranted. In TDA programs, there is a risk of stigmatizing groups that are asked to participate. These groups may already be socially marginalized if they are refugees, migrants, or ethnic minorities. Programs should avoid implementing TDA in ways that could aid to the social stigmatization of those most at risk of malaria in areas approaching elimination. Programs should avoid using language that labels these groups as infection reservoirs or as hotspots or key populations. Instead of focusing on at-risk individuals, programs can use terms that identify risk populations such as working or enjoying leisure activities outdoors at night. We will address this in more detail in the community engagement section. Unless chemoprevention interventions are part of a robust malaria elimination program, there is real risk that the gains achieved by any chemoprevention will be quickly lost. A resurgence may occur more quickly if coverage and adherence are low, if vector control operations are unable to reduce and sustain the vectoral capacity to low levels, if there's a high rate of reintroduction of the parasite, or if the surveillance system isn't operating optimally. Even with multiple rounds of chemoprevention, it is unlikely that elimination will be achieved immediately, and the effects of the chemoprevention program will wane over time. For these reasons, the surveillance system and vector control must be in place to prevent resurgence and maintain the gains achieved by prevention. Coverage is a key factor determining the success of a chemoprevention program. The program must try to reach as much of the population as possible in one or more rounds, including ensuring that no group is systematically missed in all rounds. This means that doing the same thing for all rounds is unlikely to yield much benefit. Let's brainstorm on what populations might be difficult to reach during chemoprevention programs and whether we can be creative and design a second round specifically to reach those missed during the first round. Break into small groups of 4 to 6 and consider these questions. We will ask for your ideas when we return to the full group. In sum, chemoprevention strategies cure existing infections and prevent new infections over several weeks. WHO recommends MDA, TDA, and RDA for different settings. Programs should plan carefully if implementing radical cure for Plasmodium vivax. Malaria programs should actively engage communities to plan and implement chemoprevention interventions.